So I just presented today an oral abstract in which we looked on the relapse rate in unrelated transplants that received post-transplant cyclophosphamide. And the question there is because we know that post-transplant cyclophosphamide changed the biology of the disease by upregulating T regulatory cells and knocking down T cells and cytokine production, increasing the expression of PD-1 on T regulatory cells, and also knocking down the NK, mature NK cell, donor mature NK cells. The question is if post-transplant cyclo will increase the relapse rate post-transplantation, because in patients that receive calcineurin-based inhibition of GvHD, there is correlation between GvHD and GVL. So if we reduce the GvH, maybe we are reducing the GVL, and then the relapse rate is higher. So we, in more than 7,000 transplant, unrelated mismatch or match unrelated transplant, we looked on the relapse rate compared to similar transplants that received a calcineurin inhibitor-based anti-GvHD prophylaxis, and we did not find increased relapse rate in the patients that received post-transplant cyclophosphamide. And what we observed is reduction in non-relapse mortality, reduction in GvHD with PTCy, improvement in the composite endpoint of GvHD relapse-free survival, while leukemia-free survival and overall survival was not changed. So post-transplant cyclo in the unrelated setting do not jeopardize the graft-versus-leukemia effect and don't result in increased relapse rate. And the reason for this is that there is different signature of the T cells and the cytokine production in the patients that receive PTCy. So they knocked out the T cells that are alloreactive T cells that are responsible for the GvHD, but the CD8 cells are not jeopardized, and then they can mediate the graft-versus-leukemia effect. And in patients that receive PTCy, there is no direct correlation between GvHD and GVL, so there is a separation between the graft-versus-leukemia and graft-versus-host disease.